welcome everyone. My name is Carrie Fogel. I am hosting today's Sight and Soundbites webinar, Envision for Childhood Development and Education. As you know, the Eye and Ear Foundation hosts the Sight and Soundbites webinars each month featuring different topics related to vision loss, hearing loss, head and neck cancer, sinus allergy and balance disorders, and conditions of the voice. Again, my name is Carrie Fogel. I'm the Senior Director of Development for Foundation Relations at the Eye and Ear Foundation, and I'll be moderating today. So just a few quick reminders before we get started. We won't be using the chat function during today's webinar. Instead, we ask that you submit your questions to the Q&A box at the bottom of your screen. And following the presentation, I'll ask your questions to our panelists. We do ask that you keep your questions general and not about any personal health conditions that the group may or may not be interested in. And if those questions do come through or you have them, I would be happy to send them to our speakers following the presentation and get an answer to you and send it back to you via email. Additionally, there will be a video of today's discussion available on the Eye and Ear Foundation website, as always. Okay, so now I'd like to introduce our esteemed speakers today. Our first speaker is Dr. Ken Nischal. Dr. Nischal is the Division Chief of Pediatric Ophthalmology, Strabismus, and Adult Motility, and the Professor of Ophthalmology at the University of Pittsburgh School of Medicine. He is also the Vice Chair for the Department of Ophthalmology, in addition to being the Associate Director of International Business for Ophthalmology and the Director of the Pediatric Program at the UPMC Eye Center. Prior to joining Children's Hospital in 2011, he was at the Great Ormond Street Hospital for Children in London. Dr. Nischal is a pioneer in pediatric anterior segment disease and surgery and an expert in innovative surgical techniques, disease classification, and management algorithms. Our second speaker is Mark Scaramuzzi. Mark is the Regional Director for Vision to Learn in Ohio and Central and Southwestern Pennsylvania, overseeing programs in Pittsburgh, Harrisburg, the Lehigh Valley, Youngstown, and Appalachian, Ohio. Mark's work has focused on the intersection of education and social services. And prior to joining Vision to Learn, he worked across the community in community development, workforce development, public policy, and also as an educator. So I'm thrilled about today's webinar. I hope you will enjoy it. I'm going to turn it over now to Dr. Nischal to share his slides and get our program started. Dr. Nischal.
Thank you so much, Carrie, and it's a pleasure today to speak to you all. Mark and I are going to sort of do a tag team, and I'll go first, and then Mark will follow. So I hope you enjoy the webinar. So. There we go. So I'm going to talk about visual development in children because when a child is born, they don't immediately see normally. They have to develop that vision because the brain is developing. And I want to talk about that and what influences that visual development. These are my disclosures. None of them are pertinent to the talk that I'm giving today. So as a primer, just so that we all know that we're talking about the same things. This is an eyeball in cross-section, and so the main things that I might mention are the retina, which is the photosensitive layer in the back of the eye, the pupil, which is the hole in the middle of the colored part of the eye, the cornea, which bends light, and the lens, which bends light, and then the optic nerve that takes messages to the brain. The photosensitive layer in the back of the eye, the retina, has a number of retinal photoreceptors, rods that basically see in dim light and peripheral vision, cones that help you see in bright light, central vision, and color vision. And what happens is that the message goes from one eye, and the message is split. So from each eye, you get a message that goes to the opposite side of the brain and then the same side of the brain. And that's how we get bilateral representation in the seeing part of the brain, what's called the striate or the visual cortex, which is why we can have three-dimensional vision and why the eyes work together. So just to reiterate that the striate cortex, the visual cortex, is where our central vision resides, but there are other what we call accessory areas that are mentioned here, and they're called the extrastriate cortex. And the parietal lobe and the temporal lobe play a role in what we call visual associated functions. So visual guided behavior and object perception and recognition. So, you know, sometimes as people accumulate birthdays, and they've accumulated a lot of birthdays, let's say 80 plus, you can have a problem where you might get a stroke affecting not the seeing part of the brain, not the part of the brain that controls movement, but the part of the brain that might recognize objects. And so object perception and recognition is a pathway that is associated to the main visual cortex. But I think the first thing that's really important is, what is normal visual development, right? So at 1 month, what happens to the pupils? They react to light, but in a newborn, the pupils don't react to light. So it doesn't mean that the child doesn't see, just means that the physiological reflex is not present. And the defensive blink, you know, one of the things that we do, pediatricians and you know, a family, when they have a newborn, they want to see if they're blinking to see the hand coming towards them. Well, that defensive blink isn't present till 6 to 8 weeks after birth. So if you're doing it in a 3-week-old and they're not reacting, it doesn't mean they're not seeing you. It just means that physiologically the reflex is not there. So when does a child who's being fed by the mother actually recognize that face? It's 3 weeks onwards. It's not before then. And when does a child able to see something dangling about 5 to 6 inches away? And that's by 4 to 5 weeks. So this immediately tells you that there's a development going on. And for that development to be normal, you want the development to be equal in both eyes, because information is being laid down in the visual cortex. By 3 months, children are very alert. They fix and follow toys at about 15 to 25 centimeters, about 5 to 6 inches, and the eyes will converge. So when something comes close to a child's eye, if they're 2 months old, they won't bother moving their eyes in. But as they hit 3 months, they'll be able to converge their eyes and fix on a target coming towards them. By 6 months, any strabismus, any misalignment of the eyes is now abnormal. Before then, you can have something called neonatal eye movements. And in fact, my youngest son, until the age of about 14 weeks, his eyes were all over the place. And then as soon as he hit 24 weeks, he was straight, thankfully. But you can have eyes that are wandering before 6 months of age, and it doesn't necessarily mean that you have a problem. And at 6 months, a child will reach out for an object. They won't do that before then. They might do it around 5.5 months, but usually a 3 or 4 month old will not reach out. And then they'll search for a toy once it leaves regard. So if you have a toy in the visual field of a child and you take it away, they'll look for it. They won't do that before, because actually looking for it, object recognition and object searching and perception is a much more complicated reflex than just light falling in the back of the eye and onto the brain. By 9 months, they're very alert to people. They immediately grasp toys, and babies will watch activities of people or animals 3 to 4 meters away with sustained interest for several minutes. That's the age when babies will start to watch television, because now they've got the pathways to be able to sustain attention. At 12 months, they're interested in pictures. They point to objects of interest. They point to objects of interest. And now, from 12 months onwards, until the age of 8, the brain continues to learn to see and to develop visual architecture. The problem is that there is a condition called amblyopia, and the slides, the schematic slides I'm about to show you are from a video that that is on YouTube. It's by Medical Centric. It's a wonderful video to watch, but what I've done is broken it down to explain what amblyopia is and how we can treat it. So amblyopia is the situation where there's lack of vision in one eye, usually, because of an abnormal visual experience. And as a result, that eye and the seeing part of the brain are not working in sync anymore, and information is no longer being laid down on that side of the brain. It's an early childhood condition, and as I said, it develops because of abnormal visual experience. And it's so important for us to remember that a baby is a developing neural network. They're taking on information and laying that information down for the rest of their lives. And what happens in the first 8 years of life affects visual performance for the whole of their lives. And so it's really important to pick up any problems early. If you have, for example, a defocus because a child has a refractive error, and I'm going to go into that in a bit more detail, the brain has an innate sense of how much effort it's having to put in to see. So if one eye has no significant refractive error and the other eye has a high refractive error, the brain will concentrate on the eye with the least refractive error and start to lay that information down. And it will begin to ignore the information coming from the eye that has the large refractive error because it's blurred. The weaker eye then receives less visual signals, and eventually the ability of the eyes to work together decreases, and the brain ignores the visual input from the weaker eye. Now, amblyopia normally just affects one eye, but it can affect both eyes. And that's really a problem, because if you haven't picked up that the child's getting an abnormal visual experience and the eyes remain straight, you can see a child at the age of 8 when there's very little you can do because the plasticity of the brain is set. Amblyopia is the most common cause of decreased vision in a single eye among children anywhere in the world, but especially developed countries. So as I said, rarely both eyes can be affected, and that's really quite significant. But you can reduce the effect of that amblyopia, and it can be avoided by detecting it early in life and promptly treating it. And I'm going to go through that with you now. If you leave it untreated, as I said, it has a lifelong effect. What's really interesting, and I think it's somewhat shocking, is 3% of children under the age of 6 will have some form of amblyopia. And if you look at the population census for 2022, the 0 to 5 years make up 23.4 million in the USA. That means 702,000 children in the United States under the age of 6 have a reversible cause of vision loss. And it will become permanent if we don't pick it up and treat it appropriately. See, the critical period is this period where there's plasticity in the brain. Now, animal studies suggest that the extrapolation is around 8, but if we say it's up to 6, then you know that you're going to get that treatment in time. And even if you spill over up until the age of 8, you've got that time between 6 and 8 to try and catch up if you haven't caught it early. Anything that interferes or obstructs vision in either eye is going to cause amblyopia. And that's because this is the child's developmental age. So what are the causes? I'm going to go through those now. Strabismus, anisotropic refractive, I'm going to explain what that is, and deprivation. So strabismus is an imbalance of the eyes. So if the eyes are not straight, and I'm going to show you a child who has that, instead of seeing double vision, the developing brain, what it does is it switches off the eye that's turning in. And by switching that eye off, you get amblyopia and the eye turns in even more. So that can happen if the eye is turning in or if the eye is turning out. All of this is possible. The commonest cause for the eye turning in is the need for glasses. If a child is very long-sighted and they pitch up at around normally the age of 4 or 5 with an eye turning in, if you give them glasses, the eyes straighten because the brain is no longer trying to overfocus and therefore turning the eye in. By relaxing that focus, the eye straightens. So all of a sudden, a simple pair of glasses can prevent visual loss in the eye that's turning in and also give the child the best vision that they can possibly get. Now, this is the situation that is the most worrying. You can have a child who has unequal refractive error and no strabismus, and unless the child is screened and checked, and unless the child gets glasses, the child is going to end up with permanent visual loss. And this is what the different types of refractive error are. The ones that cause amblyopia the most are farsightedness and astigmatism. Astigmatism is when the shape of the eye, instead of being like a soccer ball, is more like an American football, and that skew causes the brain not to recognize what it's seeing. Nearsightedness, unless it's very high, doesn't normally cause amblyopia, but if it's very high and the other eye is normal, it will. So as again, the brain ignores the input from the weaker eye, which we talked about, and you start to get a dominant eye, and you get an eye that is weak, if you like, and that's called refractive amblyopia. Now, rarely you can get deprivation amblyopia, and that might be because of a congenital cataract or because of a corneal opacity. But again, unless the child is screened, you're not going to pick that up. And when you have deprivation amblyopia, this needs urgent treatment, because if you don't treat the deprivation, you can't then rehabilitate that eye. If you have poor vision in one eye, your depth perception is poor. So this has a knock-on effect on what jobs you can do as you get older and enter adult life. So from a simple cause of visual loss, you can get all these knock-on effects. And it's so important that children, especially in the first few years of life, get screened and then get appropriate treatment if needed. And you really want to make the diagnosis before the age of 6. In developed nations like ours, the first eye examination is normally done by the pediatrician between the ages of 3 and 5, but not every child gets to that screening event. And so we're lucky, and Mark's going to talk about this, we have amazing organizations like Vision to Learn who will do screening at schools to try and pick these children up. Without that, we are going to be missing an important group of the population of children of that age who won't get screened, won't get diagnosed, and won't get treatment. With early diagnosis and treatment, you get an improvement in sight, and the lazy eye becomes a better seeing eye and sometimes a normal seeing eye. The treatment options, the first one is, if they have a refractive error, correct the refractive error with spectacle correction, right? And that's so simple, right? You'd think it would be. The next thing is that once you've got glasses on, then you have to patch the good eye to make the brain concentrate on the poorer seeing eye. And if you know kids, they hate having patches sometimes. So sometimes we use drops that blur the vision in the good eye so that the child can concentrate using the weaker eye. So I'm just going to pause there for a second. I think it's important to understand that there is the commonest cause of visual loss in one eye is a reversible cause. If the child gets screened and diagnosed with this condition, glasses and patching or drops can reverse that. And we have up until the age of 8 to try and reverse that amblyopia. Now, I'm going to finish and let Mark take over, but I want to share with you this website. It's called Sufi.me. It's created by the National Health Service in the United Kingdom at a particular hospital where they wanted to bring to life the beauty of vision and what happens when perhaps your vision isn't quite up to what it should be. I encourage you to go and look at this website, but this was set up 4 years ago, and they asked me to write a poem to describe how a child learns to see in the first year of life. And so bear with me while I read you this poem, and I wasn't going to, but Mark is a double major in English literature and said he wanted to hear it. So Mark, this is for you. And the poem is entitled, If I Could Remember. If I could remember that moment of birth, that expulsion from the warmth, from the comforting hues of light and shade into a bright and frosty world, what would I remember? The smell, the burning in my lungs as they inflated, from that first cathartic, gasping inspiration of treacherous, cold air. But I wouldn't remember any images, my tiny eyes shut tight, terrorized by the tsunami of new sensations, my lungs bellowing for my imperfect voice. The sound of the birth, the touch of my skin on my mother's bosom, the comfort of her milk. If I could remember that moment I first saw mother, when the blurred world focused on the love of her mother's heart, on the smile that told me I was home, what would I remember? The circular glint of her eyes and the curvy linear warmth of her mouth. And I don't guess that. That is what I would remember, because whoever created us, be it a higher power or the serendipity of evolution and a massive bang, this creation, us, we learn to see from innate basic shapes imprinted in our circuitry. Triangles and circles and lines and squares. I just learned, like you and you and you, to fill in the details. Think about it, even now as I turn the corner on my journey from birth to death, I only need a circle and 2 dots on paper for me to recognize a face. So I know that moment I focused on mother, I saw her beautiful eyes, her loving smile, because she looked at me with her heart and I at her with my curiosity. If I could remember, when I remember seeing mother's face, how old would I have been? Old enough to cry, to feed, to poop and pee, but not old enough to remember me. But now I know from teachings and science that by 3 weeks, I'd be watching her face like a hypnotized addict, especially while feeding. If I could remember when I first saw my sister, what would I remember? I'd be 4 or 5 weeks old and concentrating on mother gulping my milk and blinking like a king. I'd remember my sister swinging a bright red toy near my face, distracting my fixation. But I'd remember definitely smiling. My guardian angel would have swooped into my view. Parents are godly love on earth, but siblings are our guardian angels, keeping us safe by hook or by crook. If I could remember when I became aware of things moving in and out of my field of view, of being able to reach out and grab that red toy from my sister's grasp, I'd remember that I'd reached half a year of being on this earth, that television became the only wonder of my world by the 9th month of my existence. If I could remember what I did on the first anniversary of being an Earthian, I'd remember my joy and interest in pictures and my newfound ability to point at objects of desire and wail uncontrollably if they weren't immediately made my ward. Alas, I don't remember. People say that you can have sight but have no vision. I say, I wish I could just remember. And on that note, Mark, all yours.
And thank you for that beautiful piece, and great to be here this afternoon. Thank you to Ioneer for having me. Tough act to follow, but really excited to share a little bit of my perspective and experience. As Ken so articulately shared, vision is such a critical experience for children in their development. And as he mentioned, it's an area that with effective screening and intervention, issues can be addressed early in life, and we can ensure that children have the tools they need to be successful moving forward. But where our work comes in really is because for many children, that situation does not happen. For many of us on the call, we probably had the experience growing up where, you may have failed a vision screening at school, you may have had trouble seeing the board or noticed you were squinting, and your parents or guardians took you in, you got an eye exam, and you got a pair of glasses whether you wanted them or not. Not was my case when I was a teenager, but you had that opportunity to have that intervention and to ensure that you had the tools you needed to be able to see clearly and to see effectively. Unfortunately, for about 2 million kids nationwide, they wake up every single day and get ready to go to school and don't have the basic pair of glasses they need to go to school in order to see the board, to read a book, to participate in class. And that simple tool, that simple intervention that many of us took for granted growing up or as our children grow up, can literally reroute the entire trajectory of their lives, as Ken shared a little bit. We estimate there are about 30,000 kids just in Southwestern PA who again are waking up for school every single day without the basic pair of glasses they need to go to school, be able to engage in their learning and their education, and be able to see clearly, be able to see comfortably, to engage the world around them. That's kind of where Vision to Learn works comes in. So we were founded in 2012 in Los Angeles with a very basic premise. If you can't see, you can't learn. We know that there are millions of children waking up every day without that basic tool, and it's something that a fairly simple, effective, and cost-efficient intervention can change. Our work is geared towards addressing that need, but also meeting families where they are. We know for many families, as Ken mentioned, screening is a critical intervention to identifying these issues are there. But the second piece of that is ensuring that the care is accessible. For many of our families, the simple act of getting to care once an issue has been identified in a screening can be an insurmountable barrier. For so many of our families, transportation and access are difficult. If you can't afford to put gas in your tank right now, if you don't have reliable transportation, if you live in an area where bus lines may not take you to where medical care is, if you are in a job situation where you can't afford to take time off work, or that may be unpaid, or maybe penalized by your employer, if you have difficulties with insurance, cost, language barriers, we have so many places where we know families, even once care, a need for care is identified, they're not able to pursue those steps to ensure that their child is accessing the care they need. And that's really where our work comes in. So Vision to Learn has grown significantly over the last decade since we launched. We now have 46 clinics working across the country. We're in 14 states plus the District of Columbia. And here in the Pittsburgh area, we launched in 2018. And since that time have expanded our work significantly throughout the state. Vision to Learn operates mobile vision clinics that allow us to bring trained optical staff right to a school and deliver care right at the doorstep of where we know kids are going to be every single day. We work with the schools to ensure that those vision screenings take place. As you can imagine, in different states, the requirements operate a little bit differently on what grades do or don't get screened. So we ensure that all students in the schools that we're visiting are receiving a vision screening. Then refer them on for care for those students who, for one reason or another, may not be accessing care, to ensure that we're bringing the resource right to the doorstep of where those children are, eliminating those barriers to care that the family may otherwise be facing. Studies of our work have shown that 92% of the kids that we serve across urban, suburban, and rural high-need communities would not access care without Vision to Learn coming to their school. To be able to ensure that we can make sure these kids have the resources they need, the care they need, is so critical to their educational and life development. So the way it works is fairly simple. We bring our mobile unit. They're modified Mercedes-Benz Sprinter vans, so similar to the Amazon delivery vans you see driving around. Everything's self-contained on our mobile clinic. An optician and optometrist will come to the school. Children come on, get an eye exam. If they do need glasses, they come up front to work with our optician where they get to select a frame. We have a frame kit with over 150 different styles of glasses, different sizes, shapes, colors. We want to make sure this is an empowering experience for the children. They can pick a pair of glasses that they like, they're excited to wear. It is going to look like anything their friends or peers may be wearing. If they have friends who may have families who have the means to buy them glasses. We want to make sure that this is reducing stigmas around receiving and wearing glasses, and is an empowering opportunity for the children so they actually are wearing their glasses when they should be. So at the end of the day, we send the ticket off to the lab. We usually have glasses back about 3-4 weeks later. An optician will come back to the school, dispense glasses to the students. We can do adjustments. Again, as you may know in your own experience, if they're too tight, too loose, sliding off your face, the kids are less likely to wear them when they should be. So we want to make sure we get that great fit for everyone. And then to me, the most critical piece of our work is we will offer free replacements at any point of the life of the prescription should the glasses get broken, lost, what have you. For those of you that may have younger Students, you probably know, I usually say it's not if they break, it's when they break. So we really try to make sure that we are not just providing glasses to kids, but we're keeping them in glasses, which for many of our kids in our most difficult circumstances can be two very different things. So we're happy to replace them as many times as they need to ensure that that child has that resource every single day when they wake up for school and it's there for them, not just giving them one pair and then hoping for the best. The work we do is so critical to bridging that access barrier. For about 85% of the kids we see, a pair of glasses really will address that key vision issue that is the barrier for them. But we are so fortunate to have incredible partners like UPMC to ensure that for that 15% of students that may have more serious conditions, may have some of the challenges that Ken spoke about earlier, we can bridge that care to additional resources. We can help steward them on to getting connected with local providers or UPMC Children's Hospital to get that additional higher level of care that they need that's beyond the scope of what we can do on the van. And we know that this care is truly life-changing for almost every child we see. Studies have shown the impact of students who are able to read at grade level by 3rd grade. And we know the outcomes of this if they're not at that level. For students that aren't reading at grade level, they're far less likely to graduate from high school, far less likely to pursue secondary education. And we know the trickle-down effect of that ultimately lead to things like higher rates of heart disease or stroke, lower educational achievement, lower lifelong income. Something as simple as being able to show up to school every day and see the book in front of you, see the board in front of you, are critical to ensure that students are able to come to school and perform at their highest level and have those educational and life opportunities in front of them. We were fortunate to be part of a 3-year controlled study with Johns Hopkins University that measured outcomes of students in Baltimore City schools in our program there. It was a controlled study that looked at students who received glasses in the 1st year of the program compared to peers who received them in the 2nd or 3rd year of the study, looking at control groups and assessing the academic gains around that. And what it's found, the largest study of its kind, is pretty much what any teacher that's ever spent a second in a classroom can tell you. Kids that can see do better in school. For students who receive glasses through the program, the educational gains were equivalent to about 2 to 3 months of seat time. For students in the lowest quartile, so that's going to be your students that may have an individualized education plan, maybe in special education classes, maybe your lower learners, the gains were equivalent to about 4 to 6 months of seat time, more than half a school year. And something as simple and cost effective as a pair of glasses that many of us take for granted. So being able to provide this care to kids, and again, tens of thousands, throughout our region alone, don't have this basic opportunity to be able to go to school and see clearly and participate in the world around them. So being able to engage our school partners, engage community partners is so critical to bridging that gap for families who, as Ken mentioned earlier, may not ever be reaching that level of being screened. Or if they are screened and an issue is identified, ensuring that follow-up care takes place. State data collected through the Department of Education and Departments of Health indicate that of students who fail a vision screening through the school in Pennsylvania, only 20% a year actually ever pursue follow-up care to get the glasses that they need. 1 in 5 students are actually reaching that threshold that many of us probably took for granted growing up. So we know there's significant levels of students who just are not accessing that care. And in many cases, we find anecdotally from school nurses, they have the same students failing year over year over year. And they fall further and further behind every year academically, right? If you're failing in your vision screening in 1st grade and then 2nd grade and then 3rd grade and then 4th grade and not getting the care you need, these students are far more likely to disengage from their learning. If you can't see what's happening and you can't participate in your education, it's natural for students to start talking to the child next to them, start becoming disruptive in class because they're not able to engage with the material around them. as you extrapolate that further on, these students are far more likely to stop attending school, to drop out. Studies have found that 70% of students in juvenile justice systems have uncorrected vision issues. Something as simple as a pair of glasses can significantly reroute the outcomes of a child's life. I could tell you stories, probably to keep us here until dinner time, of some of the youth we've worked with and the stories that they've shared, the opportunities and struggles that they've faced not being able to see and learn in school. So we try to make sure that these opportunities are available for all kids. Again, not just across urban environments, but urban, suburban, and rural. Our program here in the Pittsburgh area works with almost 40 school districts across the region. Pretty much all of the high need communities throughout southwestern PA. We've seen over 15,000 students since our launch in 2018. Over 12,500 of those students have received glasses through the program. And being able to ensure that those students who have those vision challenges and may not be able to access care for one reason or another are able to have the basic pair of glasses they need to be able to see every single day. And if those glasses get lost or get broken, to have another pair, which isn't always financially feasible for families. Glasses can be a significant expense that sometimes just doesn't fit into the budget for families. So to ensure that children are able to have the pair of glasses with them every single day and go to school engaged in their learning is so critical. We've been very fortunate to have incredible partners throughout the region, not just our great partners at UPMC, but working closely with the Greater Pittsburgh Food Bank, the Boys and Girls Clubs, a wealth of various community organizations, faith-based groups, to ensure that we are getting into all the nooks and crannies and accessing kids, again, where they are within their community, and bringing care directly to them is so critical, not just to our work, but to being able to connect families to a wealth of resources and care. I tell folks that Southwestern PA is very unique because you can be in downtown Pittsburgh and drive 20 minutes and see cows. So being able to ensure that families across urban, suburban, and rural communities here have that access to care. For a lot of our families in rural communities, they may live 20, 30, 40 minutes highway miles away from the closest Walmart Eye or retail practice. And to be able to ensure that care can get to them if they can't get to care is such a critical component of what we do. But also looking at, again, for those students that have greater needs, how we're able to steward them on to the care they need. We're fortunate to have world-class resources in Pittsburgh. We have folks that come from across the globe to work with Ken and the amazing team we have at Children's. But we have students that sometimes are blocks down the street who aren't accessing care. So being able to build that bridge, to leverage those community relationships, to leverage the incredible partnerships we have to ensure that students are not just getting to that finish line if it just is a pair of glasses, but if there is a greater need, we have the resources in place, we have the relationships to help steward the family on to that additional care. It is such a beautiful piece of the work that we do. So we're very fortunate to have incredible resources, incredible partners in Pittsburgh, and certainly happy to talk further if anybody has any questions, but really appreciate the opportunity to share a little bit of our work and for the incredible context Ken was able to provide on the development of vision for children.
Wow, I want to thank you, Dr. Nischal and Mark, for a really well thought out presentation and a really cohesive presentation. Very interesting. Wow. Also to the poem, Dr. Nischal, that was really wonderful. It moved me as a mother. So we have several questions from our audience that I'd like to kind of get into before our time runs out. I'll ask them and then you both can decide who takes the answer. This one I think probably we'll start with Dr. Nischal. Is there what you would consider a statute of limitations where amblyopia can no longer be addressed or fixed because it's been present for too long?
So the only information we have is based on animal studies, and when you extrapolate that, the magic figure is 8 years. but there are children whose visual plasticity, sort of neural plasticity, sets at 7, and some in whom it might be 9 or 10. Now, that's the traditional view. There are new ways of treating amblyopia that rely not on patching, but on how you stimulate the two eyes simultaneously. And there are some exceptions where these technologies are helping young adults, in their 20s, but the rule is around 8. If you can reverse the amblyopia by 8, it's much better for that patient rather than relying on these newer technologies, some of which do work, but they don't work consistently in every adult. So around 8.
That's interesting. Thank you. As a follow-up, is that something that is like kind of widely known and communicated from a public health perspective among parents, teachers, therapists, et cetera?
So I'm a member of the American Academy of Pediatrics, and they certainly do try and, on a public health level, make that clear in their different chapters in the different states. But I don't know that by and large parents appreciate this. I mean, part of the reason for understanding how vision develops is, often I'll get young parents who didn't quite realize that the child can't see like they see. And so there is that kind of knowledge gap, and it's nobody's fault. It's just, it's just the way it is. It's difficult to explain all the different nuances of how biologically we work. But vision's so important. And I think that the issue here is if we can get the screening done. I mean, pediatricians do screen, but not all children get to pediatricians. And so if you have organizations like Vision to Learn who are doing this amazing job of getting to the schools, that's really helpful. One of the things we're doing at Children's is, with my hat, I'm medical director for digital health at Children's. We're trying to put digital health in schools, and we have a pilot at the moment of not just for eyes, I'm talking about for everything, so that the school nurse has access to a specialist if she sees a child that she's worried about. And so if she saw a child who she thought, I'm not sure if his vision's okay, and did a telemedicine review with me or one of my colleagues, we could then say, you know what, I think you need to come in, or we know Vision to Learn happens to be in this area. Can you go to their mobile, or can you go to a community center? So UPMC Health Plan does a lot. They've just opened the East End Community Center, where they have these facilities for evaluation for the population who might not want to get to a hospital or don't have the adequate insurance. So I think that we're all trying to grapple with the same issues.
And just one further question on that note, Vision to Learn, Mark, I know travels to schools across the region. Do they also travel to early childhood centers, or do we rely on the intermediate units to kind of address children who are pre-kindergarten age?
So we are working with kids pre-K to 12. And a lot of those pre-K facilities sometimes are embedded in schools that we're already visiting. Sometimes they're standalone facilities we're coming to. Sometimes those are also opportunities where over the summer we may be coming to an area and seeing a density of younger students in a community visit or a library or something of that nature. So really trying to ideally get to students as early as possible. Obviously, the quicker that intervention takes place, the better the long-term outcomes. And one of the things that I always tell everyone is vision can often slide under the radar. If a student has a toothache, or if their arm hurts or their tummy hurts, they can tell you. We often have kids who don't know they can't see. And often their families don't know they can't see. So really having that early intervention, that early screening is so critical to identifying issues and ensuring that we can get the care in place as quickly as possible.
Fantastic, thank you. Another question about some of the therapies that you talked about, Dr. Nischal, in amblyopia. Does patching or blurring the healthy eye when you're trying to correct for amblyopia, does that cause any negative effects to the visual ability in the healthy eye?
So there are a couple of things. We never patch a child under the age of 6 weeks. So sometimes we have a child born with a cataract in one eye, but we never start patching before the age of 6 weeks. And you would have to patch full time, and we never patch continuously. You're normally patching either 2 hours a day or up to 50% of waking hours. And that does not appear, from all the studies that we've done, to have a detrimental effect on the good eye. The newer technologies rely on the fact that you want to try and keep the two eyes working together. So one eye is being blurred, but the rate at which it's being blurred is not like constantly. So there are other approaches, but the way we patch and the way we blur at the moment does not affect the good eye. You'd have to be doing patching 24/7 for 6 weeks or something for it to start damaging the good eye, which we don't know.
And for a child who you may be doing that corrective method on, is it better if they're school age to do this while they're not in school, while, on a week, do you have a kind of a protocol around like when you would do that in regards to school?
It's not a protocol, it's what the child does. So what happens is I find that parents find the child cooperates with their teacher more than it does with their own parent. So I had to patch my 2-year-old girl just for an hour a day, and it was really hard to do. But when then we sent her to school with the patch, she would listen to the teacher and get patched. So I think obviously it depends on the level of how bad the vision is affected. If you have a very, very severely affected eye, then patching them at school will affect their educational development. But these children can, they can read it well enough for it not to be often, well enough for it not to be really bad. It may not be perfectly clear, but you can get the vision up from, let's say, 20/80 up to 20/30 by regular patching. And a lot of children will patch because the teacher tells them rather than the parents. Sometimes parents prefer to patch at weekends. And so sometimes we'll say, we want you to do, 14 hours per week, which is 2 hours per day. Whether you do that in 2 7-hour blocks at the weekend or whether you do it every day is up to you. So we will change it. We prefer to do every day, but we will change it depending on the patient. But the glasses at the end of the day, they're the most important thing. If a child has a refractive error and needs patching, if you don't give them the glasses, that's no good, because you've got to get that clear image on the back of the retina, which the brain then processes. And there's lots of what I love about Pittsburgh is the philanthropy. I have to mention Trucks for Maddox. This is a foundation that was started up after a tragic loss of a child's life at Pittsburgh Zoo. Many of you will remember a few years ago. And the family have raised funds so that at our optical shops at Children's Hospital and our satellites, if a parent's insurance can't cover the cost of the glasses, the fund kicks in. And I like Mark, I could tell you stories about parents breaking down in tears when they're told that we can cover the cost of the glasses, because they're so worried about where that money, what are they going to have to deprive their child of to get the glasses, or their other children of. And it's amazing, these funds make a huge difference, as Mark was saying, a huge difference.
So thinking about, a child who may not, you said children aren't often able at a young age to tell you that they're not seeing correctly. What are some common signs that, your child may be experiencing issues with their vision? So
like Mark said, the problem is sometimes there are no signs. If a child has a refractive error and is losing vision in the eye because of amblyopia, but the eyes remain straight, because with both eyes open, the child sees well, the child's not going to behave oddly. Now, if both eyes are affected, the child might be squinting a lot or might be walking into furniture. But the problem is the commonest type of amblyopia is one that affects one eye. If the eye turns in or turns out or starts to drift up, then that's obviously a danger sign, and you need to get the child seen. But the problem is that screening is needed because while schools screen and they do a good job as well as they can, these are not trained healthcare or eye care specialists. So they might overcall it, which is fine, but they might undercall it. And so this is not a criticism, it's just a fact. You know, if you have someone who's an eye care professional, they're more likely to screen more accurately than someone who's not. You can't expect a school nurse to be able to, you know, check hearing, check eyes, check joints, and be good at everything. It's unrealistic.
So this next question is kind of a two-part, and it's for Mark. What is kind of the service area of Vision to Learn in this region? And if someone is in our audience is looking to partner with Vision to Learn on behalf of a school, how could they make that happen?
Great question. So I always tell folks, our service area is kind of Newcastle to the West Virginia state line and kind of everywhere in between. We are very fortunate to have been working strategically to build out, to support communities across urban, suburban, and rural areas. So as I mentioned earlier, we're partnering with almost 40 different school districts. If you think of a higher need community in the area, we most likely are working with that school system. But again, also trying to work strategically with a range of community partners to bring our mobile unit to as many different areas as possible. We're also happy to work with families if, you know, we just had a student actually yesterday, if they're in a more affluent school district that we may not be visiting, but someone, a social worker, a parent is able to bring them over to a location where we're at, we're happy to fit them in as well. So really thinking strategically about how we can serve the greatest number of communities across the region. In terms of connecting, here, I don't know if my email shared in here, but if not, maybe we can include that in the chat or something. But certainly, you know, reach out. The easiest way is just connect with me, and I'd be more than happy to reach out. Also, you can go on our website, and my contact information is on there as well, visiontolearn.org.
Thank you. I think I have one more question, Mark, for you. Could you share, if there is anything you could share with our audience, about anything that's posing a challenge or a barrier to, you know, to the organization of Vision to Learn? Is there anything that you're experiencing? Are there any trends that you're seeing that are, you know, causing challenges or any barriers to the success that your organization is looking to have?
So I think there's two areas that I would highlight. I mean, one is we have seen significant jumps in the number of kids needing care since the start of the, you know, COVID pandemic, and especially that period of extended online learning for so many children. That extended screen time had significant impacts on vision for kids. And across the country, we've seen the rate of students that fail a vision screening jump by about 10% from pre-pandemic levels. So just more kids in general are needing vision care and needing glasses, again, in ways that are fundamentally changing their eyes that are going to be long-term consequences. You know, the second piece that I would kind of highlight is, you know, as I mentioned earlier, we've been fortunate to serve about 15,000 students across the region over the last 5 years here, but we estimate that's only about half of just the kids in Southwestern PA that need care. So yeah, it's always a question of capacity versus, you know, versus need. And we would love to see ourselves be in a position to be able to support the entire region and really get to every single child who needs vision care across the region. We're very fortunate to have some incredible philanthropic partners, some incredible community partners that make this work possible. But, you know, really it becomes a question of capacity, and we'd love to be able to see every student across the country, across Pennsylvania, have this opportunity available for them. So if there's any opportunities to think about bringing VTL to additional communities or increasing resources to make this possible, we're always happy to talk.
I just wanted to add to that. There is a lot of work at the moment about digital screens and the increased risk of myopia. And in fact, I'm on a global council where we were trying to put together evidence. And actually, it turns out that it's not the screen time, but the behavioral change. the amount of time children spend indoors on a screen has a more adverse effect than the screen itself. I mean, if they were reading a book, it would be the same. It's the fact that they're not getting out, not getting daylight exposure, which is protective against myopia and nearsightedness. That is the issue. And I think, you know, in the last few minutes, I think it's important for the audience to understand that everything that we're doing in organizations like Vision to Learn, they're essential components of delivering the care that's needed for those children who don't have access to care. But in order to, you know, to get ahead of that wave, ahead of that curve, we probably need to start thinking about other ways of doing this. You know, like at the moment, if Vision to Learn have a child who has a more serious problem, they can send the patient to us. There's other local providers. But what I'd like to see, if we can get the funding, is to have a tablet with a telemedicine component in their mobile unit, so that we can do a real-time telemedicine and make sure that the parent and the child know that they have to come to, on this date for treatment to whatever organization, rather than have to depend on them making the appointment, you know? And so there's that component. And I also, as a social determinant of health, lack of access for children is the one that really, really troubles me. And we have an opportunity here to see the effects with funding on that, the improvement in both education and improvement in well-being of the children that Vision to Learn touch. But that needs resources. You know, I would love to do a 5-10 year study where the children that have the intervention by Vision to Learn, we can follow them through and compare them to children who never got that intervention, and show that this, you know, maybe we need federal funding for this in the long term. You know, maybe we want it to become a governmental organization that does this for these children, so that we're not so reliant on amazing NGOs like Vision to Learn, Trucks for Maddox. So I think what we want to do is change the landscape so that the delivery care is more consistent, more homogeneous across the state and across the United States. Mark, would you agree with that? I mean,
absolutely, absolutely. And there's so much room for growth with the enhanced technologies that are becoming available every single day, to really increase the access to care. Again, you know, talking about Southwestern PA, this is still a fairly populous, fairly urban areas. We start to talk about central Pennsylvania and some of those areas, those barriers to care are tenfold to what families experience here. So really looking strategically about how we ensure that every child and every family, whether they live, you know, a block away from Children's Hospital or they live in a very remote, very rural area, have equitable access to these life-changing opportunities to ensure that those children have a chance to learn to their fullest potential and have lifelong opportunities beyond that.
Carrie, somebody asked the question of whether I write poetry often and why. Well, the why is easy, is because I'm alive. Why do I write poetry? For this particular poem, I wrote it because I was asked to do it. But I think it's important for parents to get information about visual development in any way they can. If it's entertaining, then that makes it a little bit easier to remember.
Thank you. I appreciate your comments, and I think that's the perfect way to end our time together this afternoon. Dr. Nischal and Mark, I want to thank you both so much for a really fascinating presentation. I know I learned a lot, and I think our audience certainly did as well. And I'd like to thank our attendees today for spending your lunch hour with us on this lovely Pittsburgh Friday. So if anyone has any questions, please feel free to reach out to me, and I can put you in touch with either Mark or Dr. Nischal if you would like to follow up on anything you heard today. And again, we will be putting a recording of the webinar on the Eye Near Foundation website in the coming days. So again, thank you to our speakers. Thank you to our attendees. Everybody have a great afternoon. Thanks again.